The following video illustrates a tonsillectomy and adenoidectomy using the Precise XP Coblation wand. The tonsil is retracted medially and the lateral capsule is identified. The tip of the wand is oriented medially and the anterior pillar is incised to identify the fascial plane around the capsule. The coagulation function effectively cauterizes vessels before dissection and controls active bleeding. Continuous movement of the wand across the fascial plane improves visibility and helps ensure uniform tissue removal. Once the tonsil is removed, remaining bleeders can be identified by retracting the tonsillar pillar. The suction removes fluids as well as any vapor plume to ensure clear visualization of the fossa. To coagulate vessels, depress the coag pedal and press the wand tip into the tissue. Hold for 3 seconds to ensure maximum thermal penetration. Orient the wand tip away from the uvula to avoid injury. Adenoidectomy is accomplished in a systematic fashion, working side to side from inferior to superior. Using light brush strokes and hovering the wand tip over the targeted tissue are key to efficient tissue removal. Optimal wand performance requires active suction. Listen for an active suction sound during the procedure and maintain a space between the wand tip and the tissue to decrease the chance of clogging. Care is taken to orient the tip of the wand medially to avoid injury to Gerlach's tonsil and the superior surface of the soft palate. Small surface bleeders can often be stopped by continuing to ablate through them. If coagulation is needed, press and hold the wand tip squarely on the bleeder and depress the coag pedal.
Hello, my name is Mr. Roland Hettiger and I am a consultant rhinologist and ENT surgeon based in the United Kingdom. We produced this educational video as a guide to health professionals involved in acute presentations of epistaxis or nosebleeds to facilitate nasal packing. After conservative measures to stop the epistaxis have failed, such as compression of the nose, ice and topical vasoconstriction, an appropriate immediate resuscitation has happened, an attempt to identify the bleeding point should occur. If a thorough examination of the nose reveals the bleeding point and the required training, equipment and expertise exist, then it is standard practice to control the bleed with either silver nitrate cautery or bipolar. If a bleeding point cannot be identified, controlled with cautery, or the bleeding is too brisk, then the next option may be to pack the nose. It is sensible to prepare the necessary equipment beforehand. Universal precautions should be implemented when attempting to pack a nose, and an assistant may also be helpful. In our department, the Rapid Rhino nasal tamponade is the first-line nasal pack of choice for acute presentations of epistaxis due to its efficacy and ease of use. The evidence in the literature also suggests it is well tolerated by patients. The internal components of the Rapid Rhino consist of a balloon pack to provide pressure, covered in a fabric made of carboxymethyl cellulose to act as a clot stabilizer. The external parts of the pack include the pilot cuff, the swallow guard, and the syringe port. There are variations in size and configuration. Packs that are commonly used in the Rapid Rhino nasal tamponade range include single 5.5 cm length packs for anterior bleeding, longer 7.5 antero-posterior packs for suspected posterior bleeding, 9 cm length packs with a double balloon for addressing more posterior bleeds, and double packs for bilateral epistaxis management. For the purposes of this demonstration, we will be using the antero-posterior 7.5 cm Rapid Rhino nasal tamponade. Remove the external packaging and protective blue sleeve. Immerse the device in sterile water for a recommended 30 seconds to ensure ease of insertion. In a clinical situation, it may be possible to prep the nasal cavity with cofenolcane spray or other suitable topical anaesthetic. In an appropriately consented and prepared patient, lift the tip of the patient's nose with your thumb and insert the pack along the floor of the hard palate, not upwards into the roof of the nasal cavity. The balloon device should sit entirely within the nasal vestibule, parallel to the floor of the nose, to exert the maximum benefits of tamponade. The blue indicator ring should not be visible outside the nose, or the tamponade device may extrude over time. The port is then connected to a syringe, which is filled with air, not saline, and the tamponade is slowly inflated to minimize patient discomfort on expansion. Care is taken not to overinflate the pack by palpating the pilot cuff. Difficulty placing the pack may be encountered with anatomical variants in the nose, such as septal deviations or large inferior turbinates. In our experience, bilateral nasal packing is not indicated unless it is difficult to identify the primary site of bleeding or the bleeding does not settle with unilateral packing. It is worth rechecking the pilot cuff after a few minutes, as the balloon can depressurize but not deflate due to the CMC fabric conforming to the surrounding nasal cavity. Always check the posterior pharyngeal wall to see if bleeding has been controlled by this method or whether further escalation is warranted. Always ensure you tape the Rapid Rhino swallow guard securely to the side of the face without any part rubbing against the alar margin. One of the advantages of the Rapid Rhino nasal tamponade is that they can be deflated without removal for an hour or so prior to decannulation. If the bleeding restarts, the balloon can simply be reinflated again and a more definitive management plan can be enacted without putting the patient through the trauma of inserting another nasal pack. Further advice can be sought from your local haematology or cardiology service regarding anticoagulant and antiplatelet therapy. Antibiotics only really required after a pack has been in situ for 48 hours, and evidence from the UK National Epistaxis audit has revealed that early removal and assessment of the nose has its management benefits. Complications to avoid in nasal packing include cardiopulmonary strain, especially in bilateral nasal packing, hard palate and septal necrosis, hence the need to check the pressure in the pilot cuff, toxic shock syndrome, hence the need for antibiotics after 48 hours, migration of the pack, hence the need to secure the pack to the side of the face, alar necrosis and inadvertent skull base penetration, so caution should be taken if there is suspicion of a skull base injury.